والteam, the unique team of neonatology in عين شمس University. الحقيقة I'm so proud to be with you. وإن شاء الله يكون مؤتمر جميل وناجح as usual, ويكون scientifically طبعا دسم. النهارده هنبتدي الفعاليات المؤتمر بالجلسة الثانية إن شاء الله. I would like to present Dr. Julian Eason. He is the leading consultant neonatologist in UK, British Association of Perinatal Medicine, with the chair of the Department of Neonatology, Corniche Hospital, Abu Dhabi. He is the co-editor of a book, Neonatal and Perinatal Mortality, Global Challenges, Risk Factors and Interventions, to 2016. We've met before several times. He is an excellent lecturer and he is knowledgeable and he is eager to teach. He likes to convey the knowledge to the colleagues, and his son is Dr. Hisham. He's your boy. His boy is Dr. Hisham Tawakkul. He is a friend of ours, and he's going to talk about. He's going to give us a lot of lectures.
It's on the screen.
Oh yeah, the neonatal parenteral nutrition. All right, thank you. Please.
Assalamu alaikum and good morning, and thank you very much indeed for the kind introductions. So, honorary president, presidents, vice presidents, coordinators, Secretary General Rana, thank you very much indeed for inviting me to this wonderful meeting. I'm very pleased to be here. I have been in Cairo before, but my wife is somewhere in the National Museum. It's her first time, and I'm sure she will love your country as much as I do. And although I'm speaking in English, in the language of science, rather than Arabic, the language of love, I do have, as an Englishman, I do have a love of Egypt, and I have a love of your thirst and quests for knowledge, and I'm very pleased to be here at this scientific meeting. So thank you once again for the invitation. Neonatal parenteral nutrition. What can I tell you? I'm sure you are all experts, but I want to give you a bit of an overview and then perhaps tell you what I do, and we can see what I think is happening with parenteral nutrition, how it differs, how it's changed over the years, and I think it's an evolving subject that's very interesting. So I come from the Corniche Hospital in Abu Dhabi. I've been there nearly 5 years. I'm probably just about to relocate back to the UK and look for another challenge. This is so we're in Abu Dhabi with the UAE with nearly about 8 million people. There's a large expat community, nearly 250,000 British people, so I'm quite at home there. But we have 64 NICU cots, but I can have over 90 babies. So probably like yourselves, we're very busy and overcrowded. Our deliveries have come down from about 14,000 to 7,000 to 8,000, and it is a hospital that has changed a lot over the years. What I like about it is we've been in the Vermont Oxford since 1998. I have over 200 infants a year, less than 1,500 grams, in fact 250 for the last 2 years, and therefore we have been able to look back at our data over the years and see how well or how badly we've been doing. So when I arrived, we were 5 consultants, and now we're 12, with 27 specialists, of course, many of whom come from Egypt, Cairo University and Ain Shams University, so I work with your colleagues. So parenteral nutrition, what can I say? Probably the first record is 1960s. Stanley Dudrick in the US achieved some success in a baby, and this baby was given, first baby to receive TPN back in 1967, and a very different recipe with very, very close observations than we would use nowadays, and this baby actually survived and went on to do very well. So clinical nutrition is important. I don't know if you have Joint Commission accreditation, but certainly nutritional screening is mandated in the work that we do, and it has been for a number of years. And ESPAN, the European Society for Clinical Nutrition, talks about the evidence of early enteral feeding, which most of us are really keen on doing now, about parenteral nutrition and what the main goal of parenteral nutrition is. So parenteral nutrition, it's really the alternative route when the enteral route is not succeeding or when it's not possible. And so we're trying to deliver this mixture closely related to requirements. It has to be safe and complication-free, and therein lies the first of the problems. So what are we going to do? We're going to talk a little bit about the indication in the neonates. We're going to outline the importance of optimal PN, and perhaps review a little bit of the content. So we're going to look at the fluid requirements, total fluid intake, energy requirements, and then a little bit about macronutrients as well. So why do we need early nutrition in premature babies? Well, glycogen is only produced in the third trimester, so there's a low tissue energy store. As soon as that umbilical cord is cut, our babies go into instant catabolism, often breaking down 0.5 gram per kilo of protein a day. And there is a natural essential fatty acid deficiency, as that is also laid down in the last trimester. So when our babies are born, we're dealing with babies who are really quite already deficient. They haven't had what's laid down, and they start to burn energy, calories, and protein immediately. So our babies often have disturbances in electrolyte, as you know, and glucose problems that we run into. Our babies often can't feed, and that's why we're giving parenteral nutrition. And there's incomplete catch-up growth and development. As you know, we have problems growing our babies. So when you leave the placenta, this is actually an emergency. You've cut off the baby's lifeline. And there's estimates of how much glucose and sugar and amino acids are suddenly stopped passing from the mother to the baby. And therefore, this baby is all of a sudden on their own. And I don't know how many of you may remember, but when I was training and we took these little babies back to the unit and we just put them on a little cannula with 10% dextrose in. And we would often keep those babies there for a few days before we decided how we were going to feed them. How times have changed, because that's not what we do. However, we still can't do much better than this. We know that when our babies are born, they all dramatically lose weight, and it's not just water. It's because we can't get enough energy and calories into these babies quickly enough, and they start to catabolize very, very quickly. So we love early enteral nutrition, and I think most people now are trying to feed these babies as quickly as possible, whether it be trophic feeds or how fast you go up with the feeds, which is another lecture and another talk about enteral nutrition, but we can talk about it. But this baby clearly needs breast milk, and often our mothers are unable to produce enough, and the amount breast milk mothers can produce varies dramatically around the world. It's can they give enough breast milk? Or we could have another lecture on breast milk banking and whether that's successful and whether that works. And that's a fascinating topic, which is very big in the UAE at the moment, as we're beginning to look at setting up small banks with known donors to help these babies. So there's some wonderful work coming out around the world on how we feed these babies. So what about enteral versus parenteral? We know enteral feeding is what these babies need, because there are positive outcomes with the GI mucosal integrity, absorption and immune function, and a lot of research and science, and maybe we'll hear some more today about how good putting breast milk into the gut is. We know that you get less infection. We know if you're nil by mouth, or we know if you're on parenteral nutrition, your chances of infection are dramatically increased. We know the liver is upset and gets complications, and we have problems with cholestasis the longer we're on various types of parenteral nutrition. And you can avoid future feeding problems if you start enteral feeding early. So what are the indications in neonates? Well, ordinarily, and I'm not saying this is a given, but usually around about 30 weeks gestation, around about 1,500 grams, if we've got a baby who's falling below that level, most of us will be thinking about whether to start parenteral nutrition on this baby, simply because of the size and deficiency. Now, you may have a different threshold. You may have a different rule for whether a baby is growth restricted or not growth restricted. I'm just saying it's a reasonable area to think about why a baby should need parenteral nutrition. So, we also know that that in the GI system, we can have a lot of problems. We can have necrotizing enterocolitis, we can have short bowel syndrome, which we'll hear about later on, we can have omphalocele, we can have all sorts of problems with the GI system that means that we cannot feed our babies. So as much as we want to feed our babies, we can have some developmental issues that means the gut won't take the milk. So that's a big problem. So those babies are going to need parenteral nutrition. What about hemodynamic instability? Well, I think gone are the days of babies on inotropes don't get parenteral nutrition anymore. There used to be all sorts of interesting myths, which we'll talk about later. But some babies who might have a severe risk of ischemia to the gut or other concerns, you may not want to put milk in that belly for various reasons. And then there are other babies who might also not be tolerating milk very well simply because of the medical conditions they have. Whether they have congenital heart disease, cystic fibrosis, severe sepsis, not all those babies may be absorbing the milk that you want them to absorb. So you have to think of parenteral nutrition. So when do you start? Well, I suppose if I go back to my days again, I trained in the 80s, we used to think about this in the first couple of days of life. Nowadays, if I haven't got a prescription up within an hour or so, then a little alert goes in and says we've failed to help this baby, and will we look at why our practice has become technically substandard. So we're tending to try and put our babies straight on to parenteral nutrition if we know they're going to need it, and we're talking about within the first hour or so of life. Ooh, good night, everyone. Of the first hour or so of life. And there's a lot of evidence, and I'm not going to go through all the evidence as to why we need to do this, except that I've already told you that cutting the umbilical cord is a nutritional emergency for all our premature babies. Lipid, we used to wait for lipid. Well, nowadays I can tell you that my lipid starts within the hour as well. There's no difference, and we start at a much higher level than we used to, and I'll talk about that in a minute too. And I do see varying practice. Wherever I go, I look at TPN recipes and I look at what people do. And I can guarantee you we're all a bit different. I'm not sure we all know who's right, but we do see a lot of differences. So what's the evidence for early optimal PN? Well, actually, the evidence isn't massive, as you can imagine, because some of these studies are very hard to do in our babies. But what we do have, we have some data talking about aggressive nutritional regimes in sick, low birth weight infants, where people have looked at aggressive versus standard nutritional therapy. Now, back in the 90s, aggressive neonatal parental nutrition is probably nothing like starting parenteral nutrition in the first hour. It's probably starting on day 1 or day 2. So when you look at these words, aggressive versus standard, you need to understand what they really mean. Because papers 5, 10, 15, 20 years ago, practices were very different than the thinking now. But in this study a number of years ago in the archives back in the 90s, they were saying, well, if you're a bit more aggressive with your nutritional regimes, you can get better growth in the early neonatal period and at hospital discharge, early on in hospital discharge, but otherwise it doesn't affect much, but it all seems to look rather good. This paper here looked at aggressive early total parenteral nutrition. Their aggressive was 3.5 grams of amino acid and 3 grams of lipid within the hour, versus a baby just on dextrose or glucose for 48 hours, and a lower amino acid and lipid to start with. And this showed that the aggressive one was tolerated. In other words, babies don't seem to have a problem if you start high lipid and high amino acids. They have an increased positive nitrogen balance and calorific intake, and there's no metabolic acidosis, hypercholesterolemia, or hypertriglyceridemia, all the things that people say in a ward round or in a research meeting that they're worried about. Oh, I don't want to give too much lipid in case. I don't want to give too much amino acid just in case the baby becomes acidotic. I don't want to do this because I'm worried about. Well, a lot of those worries were taken away by these studies, saying, well, actually, a lot of that is unfounded. You can be more aggressive when you treat babies. This was a 2013 American Society for Nutrition, Early Parenteral Nutrition and Growth Outcomes in Preterm Infants, a systematic review and meta-analysis. So this is putting a lot of the studies together in 2013, looking at whether earlier administration of PN benefits growth in preterm infants. And so it was a systematic review of all the RCTs. So this is a reasonable amount, putting a lot of evidence together. So if we look at the time to regain birth weight, if we look at all the studies, and this is favoring earlier treatment with earlier timing of parenteral nutrition, you can see most of the studies, and including the final outcome of the meta-analysis here, these are observational. Very few RCTs, as you can see. The research isn't huge in this area. You can see that time to regain birth weight was better if you start feeding early. Kind of makes sense. Maximum weight loss, in other words, you lost less weight if you fed early. Well, the studies once again showed that too. But when it came to other evidence, like weight at discharge, well, not statistically significant, but a trend. Head circumference didn't seem to alter much, and the length, once again, not statistically significant. So not every parameter we can say benefits from early nutrition, but are these the right ones to measure, and do they mean anything? Does that mean we shouldn't do it? These are the questions that have been raised since. And the conclusion from the study was early PN provides a benefit for some short-term growth outcomes, and there's no evidence that early PN increases morbidity and mortality. In other words, it's okay to do it. It has some advantages, so it seems a reasonable, sensible approach to take. So the evidence we have really is the measurement of these babies. We know scientifically the nitrogen balance of these babies is better. And we do know that from some of the studies, the disease outcomes, for example, in some of these earlier fed babies, you can get less morbidity, and ROP was an example of that. So we know that glycogen is produced in the third trimester. We know protein breakdown is more than 0.5 gram. We know these babies are short of essential fatty acids. So let's make it up for them. Let's give it as early as we can. Tends to be the thinking. So parenteral nutrition. Of course, you all know it's fluid, energy, macronutrients, electrolytes, minerals, and micronutrients. And as I said earlier, I suspect many of us have different recipes, or we buy them off the shelf from the manufacturer. We know the body composition of the baby varies dramatically. If we look at the percentage of protein and fat in these babies, it does vary quite considerably. So we know that one size of parenteral nutrition doesn't fit every single baby because there are differences. So here's an interesting one. Total fluid intake. What do we tend to give our babies? Well, day one, how on earth can you get all those nutrients in 40 to 60 mils per kilo per day? How do we do that on day one? How can we possibly do that with a standard bag, which I know a lot of us would use because it's a sensible, cheaper, safer option to use? But on the first day of life, we tend to restrict our babies down to about 40 to 60 if you're term, maybe 90 to 100 if you're preterm, but it's still not 120, 150, 180 mils per kilo that many of our babies end up on. So in a smaller amount of fluid, in our term babies, you know, we've got it. How do we get those calories in? A little bit easier in a preterm baby because you're starting off at a higher level. But once again, wherever I work around the world, the first day of life in units I've worked in has either been 80 or 90 or 100 or 110. I don't know. Everyone's different. Every unit I've been to has a different protocol for what day one fluids are, which just goes to show we still don't know what day one fluids should be. You just have to follow your own protocol. And actually, most of our babies under 26 weeks, we would start at 100 mils per kilo. I don't know if that's right or not, but it tends to be what we do. So parenteral nutrition is a part of that total fluid intake, and you have to account for other fluids. So we then have the other bigger problem of a very sick baby who we want to give let's say 80 mils per kilo, but 40 mils per kilo of that fluid is made up with drugs, inotropes, morphine maybe, whatever the baby might require. So our fluid window is very small to get in and replace those calories and that fat and that protein and that carbohydrate that we've just cut off from the placenta. We then have a very tiny bit of fluid to try and get it in on day one. And day one fluids, to try and reach that, I would say, is almost impossible, no matter how hard you try. So if you look at the basal energy expenditure and you look at the energy required for growth, for each gram of weight, and for the minimum daily 15 grams of growth, which is a figure that's often quoted, but some babies you'd be happy with 10 grams, some babies you might be happy with 20 grams, but all this takes energy. So we often say for the full-term infant you need 90 to 100 calories per kilogram per day, and for the preterm infant about 110 to 120. Now these are of course calculations based on studies, not based on studies on extremely preterm infants. So most of this, once again, is something that we are estimating that these babies require. And it's quite hard to achieve these targets, and it's quite hard to know always if we're doing the right thing. We have a lot of factors that cause us some issues here. We have heat loss. We have the extremely low birth weight infants, who obviously have a very different surface area and are massively nutritionally deficient. A baby can have a physiological stress. They will change their metabolic requirements and their calorie requirement if they're septic. Do they have a fever? Are they in respiratory failure and being ventilated? That will once again completely change what your baby's requirements are. If you're enterally fed, which is great news, actually that burns more calories. That is a process that requires energy to be able to assimilate milk. And of course then there's the simple thermoregulation too. So we need an adequate non-protein source as well as a protein source. And we know we have ratios of protein, and there are various ways you can look at these equations, but we tend to say about 30 calories per gram, and ordinarily our non-protein is dextrose and lipid, and somewhere, and we will all have different amount of dextrose and lipid that we're able to give our baby when we make our calculations for parenteral nutrition. So where do we give it? Where do we need to enter the baby? Well, ordinarily, many people will give their parenteral nutrition centrally. I've worked in some units where they will not put an umbilical venous catheter in. They will give all peripheral TPN to start with, and then put in a long line. You need to do whatever you do in your units, but many people do it very differently. Some people won't allow peripheral TPN. Some people will say it's too dangerous, or babies have had burns, and therefore you'll always get a central line. But central lines, of course, comes with problems. We know umbilical catheters, after 10 days, the evidence of migration in extreme preterm babies and complications is very high indeed. So ordinarily, you're looking to try and remove that within the first week or so. Umbilical arterial catheters, of course, when we were training, a lot of us used to give the parenteral nutrition through the UAC. Now that might seem horrific to some of you, but actually that used to be the normal route, and it works fine. But most people ordinarily wouldn't advocate giving parenteral nutrition through the UAC, but I can tell you in an emergency it can be done if you've got no other access, but ordinarily it's not the common way to give. Most of us, for longer term parenteral nutrition, will put in a PICC line, and of course this is a very good way to deliver your parenteral nutrition, but of course then I'm sure there isn't anybody in this audience who doesn't know the problems we have with coagulase negative staph and sepsis and line sepsis. And ordinarily, we currently change our lines every 14 days. We just put in a new one routinely, simply to try and minimize that risk. But that's only one way to help. And of course, I think most of us realize that as we're beginning to wind down the TPN and start with the milk, there's a deficiency. We tend to have a dropout during that transition period. Now, whether that's because the milk is not fortified, or whether it's because, or whether there are other reasons that the TPN is now being diluted or being given in a lower volume, we do know, and there's a lot of evidence that that switch, often there's a gap, and that gap needs to be thought about as we go from parenteral to enteral, because quite often that's where a baby can run into some problems. And once again, another lecture on breast milk, certainly in breast milk fortification would be interesting, is some units will fortify their breast milk always, right from the start. Some units, some places, once a baby's taking 30 to 40 mils per kilo per day of breast milk, will then fortify it. Some 100. Some won't fortify breast milk until a baby is on full breast milk feeds. Whatever you do, I suspect it's all different. And I don't know what the right answer is, except the baby needs those calories, the earlier the better, and it would appear that certainly fortifying very early on would be the better thing to do. Whether we all do it practically is another question. But there are those who will fortify right from the start. Because unfortunately, as much as we love breast milk and we want breast milk, it doesn't contain enough protein, doesn't contain enough calories for that baby to grow. So let's have a quick look at macronutrients. The early and aggressive initiation of protein with dextrose. So studies looking at preventing significant protein loss, minimalizing catabolic states, and giving a positive nitrogen balance. Early protein is good, and early protein is required, and that's one of the things that's been lacking. So what are the recommended intakes? So I wrote this because this was 2014 aspirin and Esfigan 2005. I could tell you now, we already give more than that in my unit. We ordinarily, day 1, we're giving 3, day 2, we're giving 4. So we're already using 4, and in some babies, I might even push that to 4.5. So what do you start yours at? How quickly can you go up? Your baby's catabolic. So we try and get 3 in on day 1 and 4 in on day 2. And we try hard, and I'm not saying we get there, but that's what we try. Advances, well, that's we advance by a gram. We go from 3 to 4. In the preterm, 3.5 to 4 is now more commonly recommended. As I said, we got to 4.5. In the term infant, and we then pop it back down again to 3. So that's what we try and do. But as I said to you before, getting 3 grams in on day 1 is really, really hard when you've got a small volume of fluid. So we have our starter, and apologies, it's not very clear, but it's just a shot. This is our computer, and this is our starter bag, and every baby gets a starter bag, and we pump in the protein on day 1, knowing that that volume may only be 50 mils per kilo per day, because 30 mils per kilo is taken up by something else or whatever, and we will try and optimize the protein. So there's 6 grams going into that to try and get the baby 3 grams. So we have a starter formula that we use for the first 24 to 48 hours, and it's a high amino acid concentrated formula in about roughly 10% dextrose, potassium-free, and minimal sodium. So that's how we try and do it, as much as that causes us a lot of issues in that we have to get these orders in very, very quickly, and pharmacy have to be working around the clock. So we have 24-hour call. Although it's a starter bag, we need things added to it. So we don't just pull it off the shelf, we get it from pharmacy, who will boost it up to try and get those calories on day 1. So elevated ratios of essential to non-amino acids. So we do know that, that there are some issues with some of the amino acids that we get in the amino acid solutions. And we do know that toxicity to the liver can occur. So there are different amino acid preparations. And obviously that needs to be looked at as well. But ordinarily, you're having the essential amino acids. And there's a number of papers, and once again, more research done on the type of amino acids that are required for these babies. But I'm not going to go into detail. We love carbohydrates too, and I'm mentioning carbohydrates for a very good reason, in that the brain, the chief energy source for the baby's brain is glucose. So glucose is very, very important. Glucose homeostasis we have to get right. And we know that the levels decline for the first few hours of life. So glucose will always go down, and we have to be a little bit worried about our very, very tiny babies. And the glycogen stores are gone within hours, sometimes even minutes. So gluconeogenesis starts. So there's the baby already burning its precious protein to make glucose to feed the brain. So we have to try and somehow stop that process. So ordinarily, we use dextrose. It's fairly straightforward. And the rate really that we use is looking at the rate of glucose production oxidation, what happens, the consequences of excessive glucose, and of course we do use lipid, which we need to make a factor in our calculations for glucose, because lipid can have an effect, although not a great deal, on glucose oxidation. Now, we roughly know what babies need, there's been a number of calculations about what a baby's level should be. But once again, when you go back through the data of how this is acquired, it's pretty old, and it's not tremendously accurate. It's mostly a guess. But in term infants, we think you need 8 milligrams per kilogram per minute, and in preterm maybe 6. And that is the estimated endogenous glucose production rate. So a premature baby makes less glucose than a term infant, so that's how they make it. So we know the minimum of what they require. Then how do you work out the maximum? Well, the maximum is estimated again to be about 12 to 13. So somewhere between 6 and 13 we're looking at. And we know this will vary on gestational age, and the oxidative capacity can tell you about the upper limit of infusion rate. Because once you've exceeded the oxidative capacity, you will then start, your glucose that you're giving then becomes problematical. So measuring glucose is also very important. And we know there are problems with hypoglycemia. There are all sorts of issues that can occur when you have excessive dextrose intake. And I think a number of us struggle with that. So we tend to look at our infusions as somewhere between 4 and 8 milligrams per kilogram per minute, and we advance it, and this is, as this paper was suggesting, up to a maximum of 12.5. But I know some babies do need more. Every baby's different, and that's what's a little bit confusing. And the trouble with when they get hypoglycemic is this is what happens. The insulin's ineffective, there's end organ resistance, there's more catecholamines, which will then add on to more catabolic problems. And you give a high glucose intake. How can you combat it? Well, early amino acid and lipid actually reduces the glucose requirement. So that's why high amino acid and starting lipids day 1 actually helps with your glycemic control. And that's quite important to know. And then I'm not going to go into about the use of insulin. All I'm going to tell you is we use it. Okay? We use insulin. There are those who don't. But we do. And the data, the evidence is it's possibly harmful or possibly okay. So I leave that one up to you, and we can talk about that later. But insulin, the benefit is the management of hypoglycemia. It's got some great data in adults, it's got some great data in children, but the data in neonates is a bit more equivocal, and there are risks of hypoglycemia. I don't tend to see that. Increased mortality or a metabolic syndrome due to increased early growth. Well, metabolic syndrome, once again, another lovely lecture. We can talk about protein and programming, and the use of insulin. Is very interesting. So there are risks of using insulin. All I'm going to say to you is we do use it. Lipids, I'm going to move on to lipids, and let's just get rid of some myths quickly, because I grew up with a lot of these myths, and I always like to dispel them. Increased mortality and chronic lung disease if you use lipid. There's absolutely no evidence of that at all. It interferes with oxygenation. There's no evidence of that at all. It compromises immunity. There's absolutely no evidence of that at all. The increased risk of sepsis, drummed into us. Not one paper on it, no RCTs, nothing that says giving lipid increases sepsis and causes thrombocytopenia. It's relative, it still hasn't been proven. They've been observational studies, And many of our babies, as you know, who are growth restricted, are often thrombocytopenic anyway. So these are myths. These are myths that are perpetuated. And I still hear my residents and coming up and telling me, oh, we better stop the lipid. This baby's got a gram-negative sepsis. And I'm thinking, who is teaching you that nowadays in 2017? It hasn't been true for a long time, but the myths are perpetuating. So, these are the refutes that I put in because I've referenced them, because I'm sure people would want to have a reference. It's not just me saying they're a load of rubbish. They are reference. But there are facts about lipids. The facts are that it's a very good source of energy, the best source of energy. Low volume, low osmolarity, it provides those wonderful essential fatty acids, and it improves the net nitrogen balance. So lipids are good. Essential fatty acids, as we said, you're very deficient in the last trimester. So they have a critical role in the postnatal brain development, and if you don't have enough essential fatty acids, then you'll have a number of problems. Poor growth, neurological problems, visual issues. So in the preterm infants, you can show essential fatty acid deficiency in 2 to 3 days if you don't give lipid. Now, when I started training, we didn't give lipid for 2 to 3 days because it was never started until then. That was just routine, and then we kept stopping it for phototherapy. Why did we stop lipid for phototherapy? I have no idea. There is no evidence of that at all, once again. But we used to stop it all the time. It's very, very beneficial, and we shouldn't have been stopping it. And of course, we need these linoleic acids to help prevent deficiency, and of course the omega-3s, which we'll mention a little about, which have talked about quite a lot now. Now, lipids are recommended from the first day of life. Definitely now, that's pretty routine. And we start our babies on 3 grams. And we start day 1 on 3 grams. And we will go up to 4 grams in our preterm infants. And I'll tell you why. So, oh, I like the murmurings, that's great. So liver disease is an issue. We know there's lots of different lipid emulsions. And we know that our babies get PNALD, which is a parenteral nutrition associated liver disease. And it's related to a lot of things. The amino acids, fatty acids, trace elements, aluminium, and therefore we have to be very careful to protect the liver. And the liver is a problem for all of us, as I know. And we know that we can help with the use of omega-3 fatty acids because they will replace omega-6. And we want to look at inflammation. And of course, the more omega-3 you've got, the less inflammation you've got. Now, we have intralipid. I haven't put clinoleic here. I perhaps should have talked clinoleic, which is a mixture of soy and olive. And we have SMOF. Now, we use, the lipid that we use, and I introduced into the UAE, is SMOF, which is soya, MCT, olive, and fish oil. And we now, this is a routine lipid, which is why we can go up to 4 grams without causing any problems in our babies. We don't routinely measure triglyceride levels, another myth. Nobody knows what the right level should be. And so therefore we don't ordinarily measure triglyceride levels unless there is a concern and a reason to do so, but it's not a routine monitoring for us. And we can talk about that. So the lipids you use are different, and they will have different effects. And what I can tell you is since we introduced SMOF, we dramatically decrease the amount of cholestasis we see in our babies. That was just to put the pathways of the omega-6, which are pro-inflammatory, and the omega-3, which are less pro-inflammatory. That's why we all have recently fallen in with omega-3 fatty acids, because they decrease inflammation. And that's, once again, there's a lot of studies and research. Just finishing with the electrolytes, we know we need salt. And in fact, 2 to 8, what does that mean? I've given babies 16, 18, 20 millimoles per kilo of salt. Salt, some babies dramatically lose salt, some babies lose less. Salt is something we just have to give. We tend not to give it in the first few days of life because that means the baby can retain more water, and they need to lose that water in the first few days of life. So we tend not to try and avoid it for a couple of days, and then potassium as and when required. Magnesium can be tolerated as well. Of course, mothers could have been on magnesium sulfate for neuroprotection, and so your baby's level will be very high. don't worry about it, it's fine, it equilibrates. There's no treatment you need to do or get too excited about it. Calcium, yes, added from the first day, of course, particularly in those term infants, and particularly they get very calcium deficient. It is important for bone homeostasis, and there are various ranges, and some people use total calcium, some people use ionized to keep an eye on the calcium level, as our babies do tend to get very osteoporotic, and the vast majority of metabolic bone disease can be treated with calcium phosphate, and almost never needs the use of vitamin D analogues. Phosphate, yes, we use, it's important to know phosphate metabolism. We routinely add it to all our breast milk. In fact, we have to order it. I know some people will not give out their breast milk from their breast milk banks without phosphate already being added to it, because human milk is very phosphate deficient. So our preterm babies have to have that supplemented. We talk about calcium to phosphorus ratios. There are various arguments about ratios. Ordinarily, it's just about keeping an eye on the baby's levels and keeping an eye on their bones and giving the requirements that are needed. But quite often, we're very good at giving phosphate, but we forget to give calcium. The micronutrients, well, these are fairly well selected for us in the things called, in these trace elements, peditrace, where our pharmacies will add 1 or 2 or 1.5 vials, depending on what they feel our babies require. But the longer you're on parenteral nutrition, the more likely you are to become micronutrient deficient. We see babies who get selenium deficient. We see babies who can get copper deficient. So long-term PN, you need to be a little bit more worried about what's happening with the micronutrients. So parenteral nutrition, what can I tell you? I think we all know how to do it. I suspect we all think we're doing it well. I'm still not sure if we're doing it well. What I do know is that my change in practice over the years has to become much more aggressive. And aggressive for me is not letting that baby get catabolic. So I hope I've told you what I think is right and what I think I do. And thanks very much for listening.
Thank you so much, Dr. Julian Eason, for your presentation regarding the TBN in newborn babies. I'm quite sure there are a lot of questions will be raised regarding this presentation. I myself, regarding the compounding, regarding the admixtures, regarding the cholestasis, but we will do this after the end of the session. I would like first to congratulate the Ain Shams University unit for the in ICU for organizing this very successful meeting regarding the TBN feeding and regarding the ventilation, and also to be with you for the born of the first Society of Ain Shams in ICU Society.